good winners today, some really fun things. Joseph won, and I also bought 5 tickets. And not that I wanted to win it, I was giving it to him if I had won it. So it worked out well, he won it himself, so that's good. I just want to introduce some people. A really good crowd out here today, and I think that's because we all can't remember things, and the topic is awesome. So today we have Jim Worth. Jim, raise your hand. If you were lucky enough to go to the JPL trip, Julie, who was our person who took us around, our scientist that took us around, this is her father. So you raised a very bright and wonderful young lady, so we were happy to meet her. Marianne Williams brought her daughter, and I think we already know her because Kimberly won something. So she already has her jewelry on. So welcome, thank you. And thank you, Marianne, for bringing her along with your other posse. And we know all the posse by now because they're always here with you. So we love it. Thank you for bringing all your girlfriends with you. Dennis and Jennifer Lord, they're here today. And I think this is their second luncheon. And I think I forgot to introduce them last time. So this is why I'm making a fuss over you. And Dwight and Shelley are here with Archie. Archie brought his daughter and her son-in-law. So thank you very much for being here and bringing back Archie. And I'll tell you, thank you, Archie, for coming back. We have missed you. We have missed your friendship, your wit, and just you being here. It's so good to have you back. So welcome back. Kim Sawyer is here today. So welcome back, Kim, and Barbara. And let's see, Bob is here also, Valentine. These are my people from IPF support group. So it's so nice to have them here today with us. And I wanted to introduce Kristen, who is Dr. Harwood's wife. Over here, raise your hand. And she's also into the same field as him. This is a very bright family. This is a very smart table. I think I'm going to go try to knock somebody out and sit and think of something would wear off, roll off on me. But welcome. Thank you for allowing us to steal your husband for the day. Any other announcements? Let's see. We have happy hour. No. Yeah, we have. Are we doing happy hour?
Yeah, we'll be gone.
We'll be gone.
Yeah, I don't think so.
So I don't think we have happy hour this Tuesday.
Well, I was going to come.
Well, maybe we'll have it anyway. And we don't have it in December because it falls on New Year's Eve. We don't want you out and about.
So we can't be happy until January.
The gym will be open on Tuesday and it's closed the following Friday after Thanksgiving. Okay?
Probably do have happy hour then if the gym is open.
Well, the gym is open on Tuesday, so.
I think we're having happy. Let's have happy hour.
Okay.
Come
In
on.
honor of Antoinette, we're having happy hour.
So if you haven't been to happy hour, sorry for the
That's
interruption.
okay.
It's at the DoubleTree Hotel, which is practically walking distance from the gym. And it's a great time. We have a private room. We have a private waitress. We have good food. We have good drinks. And it's just a lot of fun. And if you haven't been, you ought to go because it's the last opportunity to go this year. So we're counting on a big, big crowd, all right? It's this coming Tuesday. Yes, Sidra?
If you don't drink, you don't have to.
I don't drink and I go, and I'm wild and crazy.
We all agree with
We
that?
love you anyway.
Yeah. All right, Jackie. So this coming Tuesday, go to the gym, exercise, then go have some Diet Cokes or cocktails and sliders and pizza and all this good stuff. And it's a lot of fun. And then you go home.
You go home happy.
You go home happy. And did I ever tell you about my childhood in Wisconsin? What happened?
We heard about your childhood.
All right.
And the twins and all that stuff.
Yeah.
You do remember
Okay, I
that?
guess that's it. I'm going to introduce our guest speaker. Please, no chit-chatting while he's here. Ask questions at the end. And secondly, thirdly, if you can remember them. But I think you will, because this is a really sharp group, especially this table. So before I introduce them, please remember that they donate their time to us. And so we need to be chit-chatting with each other. Your cell phone turned off, so that it's not ringing in the middle of this lecture. Okay? This is a very special guest speaker because it's Karen Thompson's son-in-law. And we love her. Just want you guys to know we love her. And she's the one who has the smart table. And that's her. So anyway, I'd like to introduce our guest speaker. He's Dr. Dylan Harwood. He's his PhD in clinical neuropsychologist. He completed his psychology internship at the West Los Angeles VA Medical Center and his postgraduate fellowship in geriatric psychology at UCLA in the School of Medicine. Neuropsychiatric Institute and the hospital with a dual focus of neuropsychology and geriatrics. So this man is smart. So we're pleased.
I tell my wife that all the time.
And he's cute too. Welcome, and thank you for spending your time with us today.
Is this loud enough or too loud?
We're kind of hard of hearing too.
Okay.
Yeah, a little bit up like this.
Okay. So
me turn off
I'm
the
going to go
lights.
through the slides. Sometimes I have the propensity to talk quickly. So if anybody wants me to slow down, just give me the hand. I thought today I would talk a little bit about memory, but also talk about cognitive functioning in general because they usually go hand in hand. With that, I'll get started. Take me just a moment. And these are some of the things that I would like to talk about today. Defining what neuropsychology is, giving you guys some information about different types of diagnoses or cognitive issues that are associated with memory loss. For example, mild cognitive impairment versus dementia. Talking about risk factors for memory loss, protective factors, and then some of the things that you can do. Okay? And just to give you a little bit more background about myself, so I'm a clinical neuropsychologist, and I specialize in memory disorders and working with older adults. My research starting off working with older adults was actually caregiver burden and depression. That's what my dissertation was on. And then my research started to focus on memory disorders. And so looking at, for example, genetic factors that predict Alzheimer's disease or other types of dementia. Also looking at the psychiatric symptoms that are associated with things like Alzheimer's disease. And then also looking at brain metabolism and what areas of the brain predict memory loss, other types of issues, as well as what areas predict issues like depression and anxiety. And so there was a time where I was doing 50% research and 50% clinical work. Now I do less research just because of my private practice and having 2 kids and so forth. So one of the things that I'm often asked is, what is the difference between a neuropsychologist, a psychiatrist, and a neurologist? And I'm often asked that. People will say, well, I have a psychologist. And I'll say, I'm a neuropsychologist. Well, I have a neurologist. And there are some differences between us. For example, neuropsychiatrists are psychiatrists that specialize in psychiatric disorders and the treatment of those disorders. Generally, their specialty is things like depression and anxiety and prescribing medications. So their diagnostic evaluation usually comprises a clinical interview. They don't do a lot of paper and pencil tests. They don't test your memory. And if they do test your memory, it's usually like when you see your primary doctor, and every year, every couple of years, they give you 3 words, and then a couple minutes later say, what were those words, and you have to draw a clock. Does that ring a bell? Draw the face of the clock. And that's usually about the extent of what they do. And obviously, for many people, that's really simplistic, and particularly people that are highly educated, it doesn't tell you much. I can't remember 3 words after 5 minutes. So it doesn't have a lot of sensitivity. And it doesn't really have a lot of implications in terms of day-to-day functioning. So psychiatrists, once again, really their specialty is prescribing medications. Neurologists, their specialty is doing diagnostic tests to look at potentially neurological functioning. So they'll do a neurological exam looking at things like your cranial nerves. They'll look at your vision, your sensory, things like that. They may even do a CT scan or an MRI and look at the results of that scan to try to determine if there may be something that could be affecting your memory, whether that's a degenerative disorder like Alzheimer's disease, or a stroke, or something else like that. Again, most of them really won't do very comprehensive testing of memory and things like that. Oftentimes, again, they'll ask you to remember 3 words. They may do some more detailed stuff with you, but it's really qualitative. It's their impression of how you draw the face of a clock and things like that. And that's really what sets neuropsychology apart from psychiatry and neurology, is that we do very comprehensive measures that look at your cognitive functioning across the different domains, and there's a number of different things that we look at. So, for example, I'm sorry, I'm going to keep balancing the microphone back and forth with. So the areas that a neuropsychologist look at, I might be blocking the screen for some people. One of the first things that I'm talking about today is memory, or learning and recall. But we also look at other things that potentially the neurologist or the psychiatrist really won't get in great depth addressing, and that's reasoning and problem solving, looking at your attentional functioning, so your attention and processing speed, looking at your perception. And your perception is really different than your vision. Your vision are your eyes taking in the information. Perception is, what does your brain do with those images? Somebody that has advanced Alzheimer's disease, their eyes can see that that's a cake, but the brain doesn't process that that's a cake. So you ask them, what is that? And they say and sometimes they either come up with the wrong word for it or they misperceive it. So their eyes are working fine. And the occipital lobe, the part of the brain that takes in that information, is also working fine. But the other areas of the brain that interpret that information are affected. We also look at language functioning, language processing. And language processing can be things like word finding difficulties. What's that? What's that? Coming up with names for things. And also looking at what we call language fluency, which is how quickly you can generate language. So some people don't have word finding problems, but it's difficult. It's like processing speed on a RAM on a computer. They're very slow at retrieving that information. And then we also look at mood and behavior, because 1, those things can be affected by brain functioning. 2, your mood and behavior can be affected by how your response to having issues with memory and so forth. So that is an area that's important for us to look at as well. As part of my evaluation, I don't just look at things like depression and anxiety. I also see if people are having things like hallucinations or delusions, things like that. Oftentimes there can be agitation, so that can be restlessness. It can also be verbal agitation, where somebody starts swearing like a sailor. This is somebody that never used any type of curse word in their life, and all of a sudden people will say, my mom is swearing, like a sailor, and I've never heard her say those things before. So those are things that we look at as well. So one last thing that really separates a neuropsychologist from a psychiatrist and a neurologist is we do this testing, but then in terms of our interpretation, it's not our gut feeling, it's not our impression, we compare people's performances to their peers, and we do that quantitatively by looking at, for example, if we're looking at your memory functioning, if I'm evaluating somebody, I'm going to compare them, for example, to somebody that's in their 70s, that's a female, that's Caucasian, and come up with a quantitative score. Do you fall what would be considered average relative to your peers, or high average? Or we're talking about memory disorders, are you in the impaired range, so first percentile, second percentile. So that's really what gives that level of sophistication in terms of understanding how your memory is, because of course somebody's memory that has a PhD is very different than somebody that was raised in a rural county and had very limited formal education and didn't have a lot of memory requirements at their job. So to compare somebody's memory performance, it's apples and oranges, not apples and apples. So that's something that we consider. The other thing about doing memory testing is that it tends to have greater real-world implications than the neuroimaging. So oftentimes, your physician, whether it's a neurologist or a general practitioner, will have you or somebody have a CT scan or an MRI scan. And they can see if there are changes in your brain that are suggestive of a cerebrovascular disease or Alzheimer's disease. But that doesn't equate, what you see on that image doesn't always equate to day-to-day functioning. I've seen people that were MDs, PhDs, whose brains looked horrible, and they were still doing fine because they had cognitive reserve. They were able to compensate for it. So scans can be helpful, but it doesn't necessarily translate either way. If your scan looks good, that doesn't mean that clinically your memory is necessarily fine. And sometimes people whose brain scans look really troubling, and yet day to day, everybody says, she's doing fine, he's doing fine. So it's helpful in terms of identifying what the cause could potentially be. But again, just the scan doesn't necessarily tell us the full picture. Okay? Am I going too fast or talking too fast, or it's okay? Okay. So when we talk about memory loss, there's a number of things to consider, and obviously, older adults it's the fastest growing segment of the population. We look at the data. In 2011 was the first birthday for the baby boomers, the people that are kind of the young old, and this population is expanding dramatically. I had an appointment at UCLA, but I was at the West LA VA, and so my training was with all the World War II veterans, which I loved. And working with them, when I started, they were in their late 70s, 80s, and it was a wonderful population to work with. And that really kind of piqued my interest even more in terms of memory disorders. I loved working with that population. Now I'm starting to see, from that generation, evaluating the children, because people talk about what is geriatrics. Technically that's 60 and above, but somebody that's 60 or 65 is very different than somebody that's 80 or 85 or 90. Not just in terms of physically, but even just in terms of what their life experiences have been like.
I have a question.
Yeah.
Do you have any data that may indicate people with different type of diseases have an effect on the memory, like dyslexia?
Sure. Well, one of the things that's important to consider when we talk about memory loss or memory disorders is that it's a change in functioning. This is something that's acquired. It's not something you were born with. So, for example, people with a history of ADHD or a reading disorder or any other type of developmental disorder, meaning that this is something that's lifelong, that if you look at memory loss, if it's not a change in functioning, then it's not really a memory disorder. This is something that's continuous. They've had it their whole life. So, so in speaking to like dyslexia, things like that, the data doesn't suggest that people that have, for example, a history of dyslexia or a reading disorder are at any greater risk to develop Alzheimer's disease. I think what the data would show, and what I would suggest, or what I would say, is that in interpreting their data, we may have to take that into account. That maybe they were starting from a different place. There may be aspects of their memory that have always been hard for them. So this isn't a change. This is something that's lifelong or developmental. Okay? So,
Just want to remind everybody, we're going to hold all questions till the doctor finishes his presentation. So just try and remember your questions.
Okay, so oftentimes people ask me about getting older, am I going to have memory issues? And oftentimes people will say that's the biggest issue they complain of is memory loss or memory difficulties. And if we look at the data in terms of cognitive functioning in older adults, actually the domain of functioning that tends to decline most rapidly and most significantly is not memory, but processing speed. You think about it like a computer that has older hardware, it still works fine, but it may be slower at processing that information. So you do see that information processing speed decline. Memory loss is something that is associated with age. It doesn't necessarily portend dementia, but it can be concerning for some type of memory disorder. And also in looking at other cognitive issues, there also is a gradual decline in complex problem solving, as well as what I say visual spatial skills. That's the perceptual thing that I was talking about, depth perception, things like that will decline. And in contrast, simple attention and verbal abilities tend to be resistant to the effects of aging. So for example, if you had an amazing vocabulary when you were 20, the likelihood is that you're also going to have an amazing vocabulary when you're 80 and be a mellifluous speaker and so forth. So that doesn't tend to decline. In fact, it tends to increase over time. Also looking at simple attention, which is being able to focus in the short term, that also doesn't tend to decline over time. And I can attest that just in terms of seeing patients with advanced dementia, and yet their simple attention is fantastic, which is helpful for me when I do forensic cases and people are pretending to have issues, and they can't remember 3 numbers. I say to them, I say 3, 5, 2. Can you repeat that back to me? And they say 5, 7. It's just, that doesn't happen, and especially with aging, that simple attention doesn't tend to decline, okay? And this is just a graph that shows, and I'm sorry, in the back it might be small to see, but looking at longitudinal changes in cognitive abilities with normal aging. And what you can see is in looking at memory functioning, verbal memory functioning, so remembering lists and things like that, it does decline, but no more significantly than all the other issues. And one of the other striking things about this is that visual memory tends to hold better than some of the other cognitive domains. So sometimes patients may say, I can't remember things that people tell me, but their memory for things that they see. So if there's a shopping list, if they look at the shopping list, they may remember it better than if somebody says, oh, go to the market and get eggs, butter, and by the 4th thing they're saying, wait, what was it that you just said to me? But again, I put this up to really highlight that while memory does decline with age, it doesn't decline any more significantly than other areas of cognitive functioning, okay?
Could you read that list?
Oh, the list of things here?
Yeah, I can't
So-
see it.
So the first one is inductive reasoning, so that's reasoning abilities. The second one is spatial orientation, which is the perceptual skills that I was talking about. And then the other one is perceptual speed. And then numeric ability, so ability to do math calculations, particularly in your head, that tends to actually decline, more significantly actually than a lot of other areas, mental math. And then it's verbal ability and verbal memory. Okay, and so up here you can see the top one that tends to hold. Actually, I talked about language functioning in your vocabulary. That tends to, at least in this diagram, tends to show that tends to decline less than other areas. Your linguistic abilities, your vocabulary. Oh, it's catching up here. Let's see, I'm pressing to go forward. Okay. So we talk about, and I'm going to speak a little bit about the causes of memory loss and diagnostically what that means. But this list is really is a list of different things that can cause memory loss as you age. So the first one, which I'll get in greater detail about, is medications. There are a number of medications and classes of medications that can affect your memory functioning. And it doesn't mean that that's a sign of dementia or Alzheimer's disease. These are medications that in the short run can have significant effects on memory functioning, particularly as you age, but even in younger people as well. And I'll talk more about some medications because there are some that tend to have a greater effect on your memory than other things. Minor head injuries, concussions. There is research that suggests that after a mild head injury, and particularly for a matter of weeks or even months sometimes, people can have a change in memory functioning. It doesn't necessarily engender long-term memory effects. It doesn't mean they're going to get dementia. In fact, research suggests that minor head injuries like concussions don't increase your risk necessarily of Alzheimer's disease or dementia. But what they do, or how they do affect you, is that in the short run, they can affect things like your attention and your memory functioning. But again, those things tend to improve over a course, in some cases, days, but certainly weeks or months. And if minor head injuries predicted dementia, I would be in trouble because I probably knocked myself out skateboarding and wrestling and everything about 15 times when I was a kid. So far, so good. Something else that can affect memory loss are emotional disorders. And I'm not talking about like mild depression or anxiety adjustment related things, but significant emotional disorders like an anxiety disorder, like generalized anxiety disorder, or depression, that oftentimes those can affect your memory. Again, it is memory functioning that can abate once the emotional issues are addressed. So these aren't pervasive or severe issues, but it can affect memory. Okay. Also, sleep disorders. I think that really, the impact of sleep on cognitive functioning is, I think, underestimated. There is research even with younger people to suggest that in some cases, and I say some, that kids with ADHD, that there are some people or some young adults or kids that have attentional issues or memory issues, and it's because they have underlying sleep disorders that aren't being addressed, and it affects their functioning. And once their sleep improves, their memory improves. As somebody with 2 kids, they're not as young anymore, but still, when my wife and I were sleep deprived, there were times where my memory was awful because I hadn't slept the night before, I was stressed about things, and again, these weren't pervasive memory issues, but in that time frame when I wasn't sleeping well, my memory was affected. But I really classify it as a reversible type of memory factor because once that issue is addressed, memory will improve. There are some metabolic disorders or conditions that can affect memory as well. The 2 biggest being vitamin B12 deficiency and hypothyroidism. And there is research to suggest that when those issues are treated, that memory functioning can improve. So oftentimes when you're being evaluated with your general practitioner, they'll look at a number of things that are really important to memory or cognition. The first is they'll look at your B12 level and your folate levels, and then they'll look at your thyroid functioning. So there's hypothyroidism and hyperthyroidism. Hypo, which means it's not working as well, is the one that's linked with memory issues or cognitive issues. Again, once the hypothyroidism is addressed, the memory issues will improve. People with hyperthyroidism, which is Hashimoto's disease, tend to look like they have manic depression. They tend to be, talking quickly. I don't think there's a lot of research that they have memory issues. It's more related to the hypothyroidism. So, specifically with respect to medications, there is a growing body of literature that suggests that certain medications can impact your memory functioning. Probably the biggest culprit are medications that are anticholinergic. And why those medications affect your memory is that there's neurotransmitters or chemicals in the brain that are linked with different stuff. So for example, dopamine can be linked with attention functioning. Serotonin can be linked with depression. Like antidepressants are SSRIs, they affect serotonin. Acetylcholine, which is a neurotransmitter, is the primary chemical that's implicated in memory. And when you take medications that deplete your levels of acetylcholine, it can affect your memory functioning. Some of the biggest culprits are some of the old antihistamines, for example, diphenhydramine, which is in a lot of different medications. It's not that if you take it a couple times it's going to affect your memory functioning, but I have patients that don't sleep and they say, oh, I take Tylenol PM every night, or I take ibuprofen PM every night. And that's not necessarily a good thing, because depleting those levels of acetylcholine can affect memory functioning. There also are other medications that, and I put a link at the end that shows different types of medications that have high anticholinergic properties. So that's at the end of the handout. So if you want to go and look at it, it doesn't mean that you shouldn't take those medications, because a lot of these medications are helpful. But there are certain ones that you should just be mindful of, and sometimes people taking them for long periods of time, that they may be underlying some memory issues you're experiencing. Meclizine, which people take oftentimes for seasickness, things like that, or stomach problems, can have an effect. Some of the medications for urinary incontinence can have high anticholinergic properties. So I list a couple of them, there's two there, Detrol and Ditropan, that have high anticholinergic properties. But I'm not suggesting that these are the biggest culprits, but just kind of an example of some of these medications that can affect acetylcholine levels in memory. So one of the issues that I'm always asked is, if I'm having memory issues, does that mean I have dementia? No. Again, I talked about things that can cause memory loss, like sleep disorders, hypothyroidism, things like that. But as a neuropsychologist, when we look at memory functioning and looking diagnostically, there's a couple things we're looking at. One is this a change in functioning from prior levels? So I talked about like the dyslexia or the reading disorder. Is this a change in functioning? Yes. Did it happen acutely, or is this something that has been kind of progressive? And when we talk about the difference between mild neurocognitive disorder, what they call mild cognitive impairment, MCI, versus dementia, is that the difference with dementia is that not only are you having memory loss, but the memory loss or other issues that you're having, if you look at the third bullet point down, the cognitive deficits interfere with independence and everyday activities. So if you're having memory issues, they may be a nuisance, they may be frustrating to you or your spouse or your children, but at the end of the day, do they significantly impact your ability to do things independently, like balance your checkbook, or pay your bills, or follow up and schedule appointments with your physician, or remember to take your medications, things like that, more complex day-to-day activities. You may be aware of the difference between ADLs and IDLs. So ADLs are activities of daily living. Those are things like, can you feed yourself, can you shower, can you put your clothes on, which tend to be when people are having greater issues, but it's the IADLs, the instrumental activities of daily living, that are day-to-day activities that take more cognitive functioning, planning, reasoning, things like that. They're more sophisticated, like balancing your checkbook. Balancing your checkbook is a lot harder than eating, although I would suggest that for my kids, not necessarily, but so we're looking at, is there a change in memory functioning or other cognitive issues, and are those pervasive, and are they significantly impacting the person's day-to-day functioning? If they're not, and many people will say, there is a change in my memory functioning, there's things, I might forget things, but I can still do pretty much most of the things I wanted to do. I don't forget to pay my mortgage. I don't forget to take my medication, and if I do, it's seldom. The problem is when it's pervasive, when people are forgetting that stuff every day, and the family has to step in, or somebody has to step in, to take care of those things. So I put some things in here about signs of Alzheimer's disease or other dementias, and I'll kind of just go through them quickly. I don't want to spend a lot of time on them. One of the questions that I'm often asked is, what's the difference between dementia and Alzheimer's disease? Does anybody know? Yes. Exactly. So the difference between dementia and Alzheimer's disease is dementia is just how we characterize the cognitive issues. So a change in memory functioning or other cognitive issues, like I said, that affect everyday functioning. So it's how we characterize the symptoms that people have, but it doesn't say what the cause is. Alzheimer's disease is the most common cause of dementia. It is one of the issues that can cause dementia. Dementia can also be related to stroke. It can also be related to things like Parkinson's disease or severe head injuries, things like that. So if you have Alzheimer's disease, you have dementia also. But people that have dementia don't necessarily just have Alzheimer's disease. So, probably 80 to 85% of all dementias are related to Alzheimer's disease or some combination. People may have some Alzheimer's changes in the brain, but then they've had a stroke or a significant head injury. For that we'd say it's a mixed dementia. It's a dementia related to multiple causes or etiologies. So some of the symptoms or signs that characterize dementia or Alzheimer's is memory loss, as I talked about, that disrupts your daily life. Also affects things like planning and problem solving. People are unable to complete familiar tasks at home or work. They might get confused with time or the place. Other things, and I'll go through these pretty quickly, but problems with speaking or writing. I talked about language functioning. People have word finding difficulties. Not that's really at the nuisance level, but so significantly that they have difficulties communicating. So if they say, "Can you pass the cup?" they'll say, "Can you pass the bup?" or the, and they can't come up with it. And again, changes in mood and personality. I think that tends to be underestimated in dementia. Oftentimes people, they worry about their loved ones having problems with memory or things like that, language functioning and so forth. But what tends to affect family members and other people in their lives more than anything are some of the behavioral or changes that happen in dementia, the agitation, the delusions, things like that. But so there are a number of risk factors for memory loss and just cognitive decline in general with age. One of them is age, obviously. That the risk of memory loss is greater among older adults than younger adults. I mean, that's well established. There are other things that can affect the risk for memory loss. One of them is genetics. And when we look at genetics, there really is a difference between early onset and late onset. So by that I mean that genetics tend to play a much greater role in early onset dementia than dementia in older life. So for example, people that develop dementia in their 40s or 50s, that tends to have a very strong genetic component, and usually is what we call autosomal dominant, which means if you get the gene, you get the disorder. A similar thing would be like Huntington's disease is a neurodegenerative disorder that's very similar like that. But in those cases, you see throughout the family, you look back, you look at your cousins, grandparents, so forth, and you see that a lot of people have it. Dementia that develops in the 70s or 80s, there is a genetic component, but it is much lower. And so when patients come in and talk to me and say, well, both my parents had dementia, but they developed dementia when they were 90 years old, I say, I think the greater factor for them was age and not necessarily genetics. So I tell people usually to not be as concerned about that because it doesn't play as much of a role. And if you just took a random group of people that were 90 years old and you looked at the prevalence of memory loss or dementia, it would be high regardless of all these other factors. There are other factors that can affect memory as well. Many of them are related to cardiac functioning or stroke. Traditional risk factors for those types of things: high cholesterol, hypertension, diabetes, smoking. I think that years ago, those issues raised the risk of people developing vascular dementia, or dementia related to stroke. But what research is tending to find now is that some of those traditional vascular risk factors also increase your risk of Alzheimer's disease. Also talked about a history of head injury, not a mild head injury or concussion, but a very severe head injury where people lose consciousness for a significant amount of time. That can increase your risk of memory loss. But I really draw the distinction between not a concussion, not a mild brain injury, but a significant brain injury. You've probably seen in the literature the issue with the NFL and hockey players and people developing dementia. And what they're finding is that people that have repetitive head injuries, many of them over the years, that it doesn't necessarily increase your risk of developing one type of dementia or memory loss, but that in general it lowers the threshold, the age of onset for a number of different degenerative disorders or memory loss. So people that have many of these head injuries might develop Parkinson's earlier than they would have, or develop Alzheimer's disease more than they would have. And education level. Education level is important. And really I think that the most important factor or salient factor related to that is cognitive reserve. If you have more, you can afford to lose more. So I talked about people's brains that looked awful, and yet they were functioning fine, and it's because they had that cognitive reserve. So people that have higher levels of education have a lower risk of developing dementia. It may even be that neurologically or neuropathologically in the brain that they have the signs of Alzheimer's in their brain, but their brain is compensating for it, and so they don't have symptoms that are that significant. Okay, so it's really compensatory mechanisms. So there, I talked about kind of the downer, which are the things that increase the risk of memory loss, but it's also important to identify things that are protective factors for memory loss, really across the lifespan. A number of things, obviously higher education, which I touched upon, because of the import of that with respect to cognitive reserve and compensatory mechanisms, but also recent research has shown that there are a lot of other things that can decrease the risk of dementia later in life. One is computer use. You think about when you're using the computer, and I'm not saying necessarily like solitaire or something like that, although even with that, there's planning and strategy. So with everything, there's planning and strategy. But depending on your computer use, there's a lot of cognitive processes that go into that, and that decreases the risk of later cognitive decline. Artistic and craft activities. So those research has shown that as well is a factor that can decrease the risk of developing memory loss and dementia. Regular physical exercise, which makes a lot of sense. In order for the brain to work efficiently, it needs to have fuel. And how does it get fuel? It gets fuel from blood and oxygen. So if you're doing more exercise, you're getting more oxygen to the brain. And that's a good thing across the lifespan. Also, managing cardiovascular risk factors, things like diabetes, obesity, smoking, things like that. And a healthy diet, which I'll kind of touch upon in greater detail in a second. And then, of course, this shouldn't be a shock, but lifelong learning and cognitive training. If you're using your brain throughout your whole life, you're exercising it. That is building your cognitive reserve and your compensatory strategies. So this is kind of in small print, I apologize. Speaking of dietary factors, what research is really showing is that a number of different foods that are in a Mediterranean diet have neuroprotective effects. And so we look at what is a Mediterranean diet. Everybody talks about it, that sounds great, but then what is it? So, a Mediterranean diet includes a variety of minimally processed whole grains and legumes as staple food, a huge diversity of fresh vegetables consumed on a daily basis, fresh fruits as a typical dessert. It's not in my household. Sweets based on nuts, olive oil, and honey consumed generally only during celebratory occasions. I mean, this is a real traditional Mediterranean. They're obviously, nobody's going to follow this to the T, but still there's a lot of good stuff in here. Cold pressed extra virgin olive oil, nuts and seeds as a principal source of fat. Moderate consumption of fish. Dairy products are consumed in low amounts. Things like butter, cream, and milk are never used, although I think that some people are going to consume some amounts of those. Red and processed meats are consumed in very low frequency, particularly because they're a high level of saturated fats and cholesterol. And then wine is consumed in low to moderate amounts only with meals.
3 meals, including breakfast?
Yeah, exactly. Well, beer's not just for breakfast. And people say, I just had 1 glass of wine, but then they show me it was the whole box of wine. No, so other foods that may have protective cognitive effects. One is blueberries. Blueberries have high levels of flavonoids, which appear to have a neuroprotective effect. And there is even some research that even in shorter periods of time, that people that consume fairly large amounts of blueberries over a course of, say, a couple months, they can even show some improvements in memory. Oftentimes when we talk about foods, it's not that it's going to improve your memory functioning, rather it's going to decrease the risk of developing memory loss. Also grapes. And so flavonoids actually are one of the polyphenols that are rich foods. So grapes is one of them. People used to think, oh, there's only red grapes, but actually research shows that it doesn't matter if it's red grapes or green grapes, that the properties that are neuroprotective in grapes are in both. Right? Also, foods that are high in omega-3 fatty acids. So fish, one of the types of fish that has the highest level, obviously salmon. But you can find that information. Not all fish has high levels of omega-3s. Some are better than others. Also, vitamin E rich foods like almonds, avocados, and olive oil can have neuroprotective effects, and helps to explain why the healthy aging in some of the Mediterranean climates, and based on their diet, that these people have lower risks of memory loss and dementia. And also minimizing foods that are high in saturated or trans fats. Those are bad for you. They're bad for your heart, they're bad for your brain.
What about B12?
What's that?
B12.
Yeah, B12, absolutely.
Well, where is it?
So, speaking of B12, so there are 8, it's probably more information than most people want to know, but there are 8 B vitamins collectively called B complex vitamins. So B1 is thiamine, B2 is riboflavin, B3 is niacin, and so on and so forth. And what research really shows is it's not all the B vitamins that really are good for your memory or good for your neurocognition, but rather that there are 3 specific ones that are implicated in memory. B6, B9, and B12. So some of the B6 rich foods, turkey, beans, spinach, foods that are rich in B9, legumes, leafy greens, broccoli, and foods that are rich in B12, certain types of meats, milk, and fish. You can find a lot of this information online. If you go to dietary sources, they give you really, good ideas about different foods that you can eat that are high in these vitamins. One of the things that's important to remember is that taking supplements in some cases is different than getting these vitamins through dietary sources. One of the problems with taking vitamins is that you excrete. Most of them are water soluble, and you excrete them. You pee, and they come out. Getting them from foods, you break down the food, you metabolize them, so it's more potent, and I think has a greater impact if you're able to get these vitamins through diet. Okay. And I think there's also the added benefits. For example, leafy vegetables, not only are they high in different types of vitamins, but they also have the roughage, and so it also improves your gastrointestinal functioning, and you're able to keep the system flowing, which also helps to just eliminate stuff in your body that it doesn't need. So food is always the best option in terms of getting vitamins. I saw something recently that said that Americans have the most expensive pee in the world. And it's true, because people take so many vitamins, and many of them, again, you pee them out. Your body doesn't metabolize them, you don't use many of them, and it doesn't have the same impact. And if you walk into Sprouts or Ralph's, you'll see all these, this is for your health, this is for your mind, this is for memory, this is for your mood. And research doesn't oftentimes doesn't support any of that. And then you look at the fine print and it'll say this is not a medication, and there's the disclaimer that's in like a 1-point font that maybe you could find with a telescope. And so, I always suggest that people get these vitamins from food. So, looking at the literature in terms of what can you do about like medications for mild cognitive impairment or just memory issues, but they're not so significant that that they affect your day-to-day functioning and they don't warrant a diagnosis of dementia. Well, what research has shown, some meta-analyses, is when they pull data from a lot of different studies, and that allows the researchers to be much more powerful in terms of looking for findings. What they find is that if people don't have dementia yet, but you give them all these different types of medications, they don't necessarily have a big impact. So in persons with normal cognition or those with mild cognitive impairment, which means cognitive issues but not dementia, that taking these medications doesn't improve, nor does it slow down the decline of functioning. So they've looked at Alzheimer's medications, hypertension medications, all of these different medications, and they don't necessarily have an impact on your cognition. So, people go to their physician and say, well, should I take an Alzheimer's medication? Well, research suggests that it doesn't really, if your issues are not that severe, that it doesn't have a big impact. In fact, the Academy of Neurology came out with a consensus statement a number of years ago that said, we do not suggest that patients with just memory issues but not dementia, we do not suggest that they take Alzheimer's medication to improve their functioning because it doesn't have a big impact. Okay, which speaks to the things that and I'll get to some things that you can do about your memory. And there is emerging research that really shows the benefit of different types of cognitive exercises. I talked about doing those things throughout your life to decrease the risk of developing memory issues, but there also is some research that shows that there are certain types of cognitive programs that you can do, training that you can do, that may improve your memory. And so there's a lot of stuff out there. I'm trying to think what was in, like Lumosity comes up on your phone all the time. Some of these things, there isn't a lot of research behind it. Can they have an impact? Potentially, but I'm always reluctant to suggest that people do stuff unless there's some science behind it and there's empirical data to show it makes a difference. There are a couple programs that actually do have some science behind them. One of them, and I put links in the back of this presentation, one of them is called Cognifit. It was a company that was developed in Israel not many years ago, but now it's probably been over a decade. And they've looked at the use of Cognifit for memory issues with people that have had, that are pre-dementia. They've looked at people that have had head injuries, Parkinson's disease, and it shows that they can have some benefit. One of the things, there's another program too that's called Active. They were utilizing that at UCLA. I have the link in the back. It's actually Brain HQ is the particular program, but I have the link on there so you can click on it and kind of read about it. But again, some of these programs are good because what they do is they establish a baseline. So they'll do some memory testing with you online, and they'll look at where you're at, and then they'll tailor the intervention to your level of functioning, which makes a lot of sense. One size doesn't fit all. If people have very mild issues, they'll start you maybe with more challenging type of tasks. One of the things that the research also suggests with respect to any of these programs is that it's not transferable. By that I mean, if you're doing verbal memory exercises, it's not going to improve your language functioning. It's going to improve the specific cognitive domain that you're working on. Okay, so there isn't that generalizability. It's like somebody saying, well, I'm a sprinter and I work on sprinting, but that's not going to make you a great high jumper. It's only going to make you fast at running. So it's domain specific. And these programs don't just look at memory, they do look at other types of things like visual perception and language functioning, but they work on them separately, okay? And then also, again, I say cognitive enrichment may decrease the risk of neurocognitive decline in older adults. And the key thing here is that have not been diagnosed with dementia. a lot of the research, there's been a lot of studies that have looked at if you do these memory exercises in people that have dementia, will it improve their functioning? And in some cases, yes, but the gains don't tend to be sustained. So people may show some improvements in the short run, but some of those changes aren't necessarily consistent over time. And that may just also be a reflection of the memory loss becoming more severe. There's a neurologist whose name is Dale Bredesen, and he's developed a comprehensive program. It's called the Bredesen Program. He did not pay me to say this. There are some neurologists, some UCLA neurologists that I know that really have patients employ this whole program. It's a very comprehensive program that looks at your genetic functioning. They look at micronutrients, so they'll have laboratory studies that don't just look at things like folate and B12, but they'll look at metabolically, how do you process certain vitamins. I mean, they do a very comprehensive diagnostic test for everything. And then he tailors an intervention that's specific for your body type and any nutritional deficiencies you have, as well as cognitive training. And so I have a link to the website actually here, but he also has a book from 2017. I've not met him personally, but I do have respect for the work that he does. And there are a lot of really good behavioral neurologists on the west side that I know that follow his protocol. And so I have some resources here. The first is his book from 2017, The End of Alzheimer's, the first program to prevent and reverse cognitive decline. The second link is a book from a psychiatrist at UCLA. It's called The Memory Bible, an innovative strategy for keeping your brain young. In that book, there are strategies that you can do day to day, little tricks that you can use to kind of improve your memory functioning. I also have the website for Brain HQ, which was the active that I talked about, that program, as well as Cognifit. And then I did put the link in there for medications that have strong anticholinergic properties, so that as a reference, okay? And with that, questions? Sure.
Yes, I noticed the first three letters of your organization have to do with N-E-U-R-O, and I'm wondering what it has to do with neuropathy.
Which?
Neuropsychology.
Oh, well,
I'm wondering what it has to do with neuropathy, specifically peripheral neuropathy.
yeah. So
Same thing.
it's related to neurological functioning. Ergo, the neuropsychological functioning usually is looking at the central nervous system, so the brain, not even the spinal cord, but generally the brain. Neuropathy stems from peripheral nerves that are damaged from, for example, diabetes or high glucose levels over time, which can lead to, to that pain and so forth. Yeah.
Can you repeat the question when they asked?
He was talking about the neuro in neuropathy and if that related to neuropsychology. And I was talking about that they both relate to neurological functioning, but we were really interested in the CNS, the central nervous, the brain, whereas he's talking about neuropathy, which is the peripheral nervous system, like carpal tunnel. That's a peripheral nervous system issue as well. I've had forensic cases of people with carpal tunnel or peripheral neuropathy that complained of brain problems. I said, no, they're separate stuff. And having peripheral neuropathy doesn't necessarily increase your risk of memory issues, but the diabetes or the hyperglycemia over time could affect memory. So they may be related in that way.
How could you speed up recall?
How could you speed up recall?
Slow it down.
Yeah. That's a good question. Oftentimes, memory loss and aging, it's not really that people are amnestic, it's a retrieval issue. So people will say, the information's in there, but it's like a file cabinet that you know it's in there, but you can't get at it as quickly. And you know you're going to get it eventually, you're like, it's going to come to me as soon as I walk out the door. Yeah, the retrieval issue. And in terms of speeding up, I think that in terms of that efficiency of retrieving things, repetition tends to be, or familiarity tend to increase that. So I don't know, just off the top of my head how you can improve that retrieval speed other than if things are automatic. If you put stuff in familiar places, if you think of mnemonics in terms of remembering stuff that are more familiar, that you might be able to make that connection and drop that information more quickly. In terms of the retrieval speed, that also relates to processing speed, and that's just something that's associated with age, that speed tends to decline, which for some people doesn't bother them, and for some people it's really upsetting because